Okay, I think we can move to the next round table, which is related to histopathology and adjuvant treatment. Before we do, I really like to congratulate the organizers for putting together this very high quality meeting, and thank all the experts who shared their time with us today. And I think it's going to be fruitful for everybody interested in colorectal cancer. With that, I will turn the microphone to Professor Zardi, who's going to introduce the first two speakers.
And good morning for me. And I would like to invite Dr. Nick West, a gastroenterology pathologist with special interest in colon cancer. And she's focused about the impact of extended quality of surgery and oncology outcomes. Please, Dr. West.
Thank you very much for the introduction, and thank you to Professor Zinos and colleagues for the invitation to come and talk to you about what we can do as pathologists in terms of feeding back to surgeons about the oncological quality of colon cancer surgery. So we've already heard this morning about the lessons we can learn from rectal cancer, and going back to the 1980s, of course, we know that the introduction of total mesorectal excision for rectal cancer resulted in a significant improvement in long-term outcomes. And we know from Phil Quirk's work at the time that pathologists feeding back on the quality of specimens can help to improve the overall quality of surgery and oncological outcomes. Initially by reporting the importance of avoiding tumour at the circumferential resection margin, and then later the importance of grading the quality of surgical specimens, and the mesorectal grading system was initially devised using this three-tiered grading system where we have an intact mesorectum in the mesorectal plane, intramesorectal plane with defects, and then exposed muscularis propria. And this was prospectively tested by local pathologists in the UK CR07 trial, which was a randomization between short course radiotherapy and straight to surgery with long course chemoradiotherapy if you had a positive margin. You can see that there is a significant prediction of local recurrence based on the pathology grading, with the muscularis propria plane having twice the rate of local recurrence at 5 years. So when we look at the evidence for variations in outcomes in colon cancer, here are two pieces of data. The first from the 9 Stockholm hospitals, and from the bottom all of the English NHS Trust from Eva Morris. And you can see that there is significant variation in both of these data sets between the best hospital and the worst hospital in terms of long-term outcomes for patients with operable colon cancer. Now, there are lots of factors that can contribute towards this variation in outcomes, but we believe a major driver is the quality of the surgery. And we know this as pathologists because we get to see specimens from a wide variety of surgeons through the trials across the country or even internationally. And we know, for example, that some specimens will look like this, a very short piece of colon with very minimal mesentery attached, and on the cross-sectional slices you can see significant defects going down to the muscle. Whereas other specimens have a nice intact mesentery, and you can see on the cross-sectional slices no evidence of defects into the mesocolon. So we know there is significant variation in the quality of surgery, and we hypothesize that it's a major reason why we're seeing this variation in outcomes. So what are the variables? Well, we've already heard about the 3 main variables with colonic cancer surgery. The first one is the mesocolic plane, and to look at this as pathologists, we devised a grading system similar to the mesorectal grading system. So we have the mesocolic plane with an intact specimen, the intramesocolic plane where we see defects into the mesocolon, and then the muscularis propria plane where that resection plane lies on the muscle tube. Then there's the height of the vascular ligation, As pathologists, we can only assess what's in front of us on the specimen, so we can measure the distance between the bowel wall and the high tie. But of course, we can't comment on what's been left behind. And as we've just heard from Nick, the study we did in Denmark showed that actually there are substantial lengths of the colic arteries left behind on those post-operative CTs, despite the fact that the surgeon claimed to have undertaken a high tie. And then we've got the length of colon resected, and we know there are two different approaches when you compare the European CME approach with a much longer length of colon, with Professor Homberger's approach going to the next vascular arcade beyond the tumour, and the Eastern Japanese approach, which is based on the 10 centimetre rule, with resection of a much smaller length of colon. So if we start with the mesocolic planes, this was our initial study, published 10 years ago now, looking at just under 400 colon cancer resections from Leeds between 1997 and 2002. We used the 3-tiered grading system, and we were able to show that actually at this time period only 1/3 of specimens were resected in the mesocolic plane. So 2/3 of all colonic cancer surgery in Leeds during this time period was not optimal. 24% in the muscularis propria plane, so major defects going down onto the muscle tube. And when we look at the outcomes for all cases, we see a 15% difference between the mesocolic and the muscularis propria plane at 5 years. This is overall survival. And when we specifically look at the stage 3 group, we see that distance becomes exaggerated, as you would expect, because we've got disease within the mesocolon, with twice as many patients alive at 5 years with mesocolic plane surgery compared to the muscularis propria plane. When we undertook a similar analysis on the MRC Classic trial, we had slightly fewer cases, around 160 cases, so we've combined the mesocolic and the intramesocolic plane groups versus the muscularis propria plane. But you can see the survival curves are very similar for all cases, around a 15 to 20% difference at 5 years. And for stage 3, again, twice as many patients alive with better surgery compared to the muscularis propria planes. The other thing we have from the classic trial is local recurrence data. And you can see if you have muscularis propria plane surgery, your risks of local recurrence at 5 years are above 20%. Versus less than 5% if the specimen is intact. But as we've also heard from Nick, there are problems with the pathologist's assessment of specimens. This is a subjective assessment, particularly if it's being done retrospectively on specimen photographs. And we did a study in Denmark with 4 pathologists and 2 surgeons grading 2 sets of 50 specimens twice. And when you look at the variation between the observers, you can see, this is me here, 63% of the specimens I graded in the mesocolic plane, but you can see amongst the other observers, some as low as 41%. And when we undertook the analysis again, around 3 to 4 months later, we do see that we change our opinions on the same specimens. So it is a subjective assessment with significant inter and intra-observer variation. On the back of this study, we therefore decided that we needed to refine the grading system to make it more reproducible between pathologists, because that simple grading system of just looking for the presence of defects could be interpreted by different pathologists in different ways. So we've since made some refinements to grading. We've said that we should be concentrating on grading the mesentery present, whether or not it's an extensive mesentery. So this is an example of a D2 resection, possibly even down to D1 here, with a very small amount of mesentery attached. Some pathologists were interpreting this as being intramesocolic based on the small amount of mesentery present, but we decided that we should just grade whatever is present as either intact or not intact, rather than comment on the central radicality that should be assessed in a different way by measuring the distance between the tumour and the high tie. We also said that we should only base our assessment on the lymphatic drainage area to try and increase reproducibility, and the Japanese have published some nice guidance for what constitutes the lymphatic drainage area for the various vascular configurations. We said we would allow a bit of leeway for mesocolic windows, so if the specimen was generally intact, apart from a single perforation of the peritoneal windows, then we would still allow that to be a mesocolic plane excision. And we also tried to clarify some of the issues we'd noted, particularly with laparoscopic surgery around the hyati. So if there was a bit of separation of the vessels, then we wouldn't downgrade, but if we see defects into the mesentery overlying the vessels, then we would downgrade into the intramesocolic plane. And an appendix to the previously published Danish paper goes through these refinements in more detail and hopefully will make it a little bit more reproducible between pathologists. Then we come on to the concept of the height of the ligation, and we've already heard from Professor Hohenberger the European CME approach, and we've looked at many specimens from Erlangen over the years. Here you can see two left-sided and two right-sided examples where you can see there's clearly a more extensive mesentery compared to the original Leeds series with a high vascular ligation and nice intact mesenteries, and here you can see the intact mesocolic windows. And we've also had specimens from Japan, and of course in Japan they undertake a similar operation in terms of the height of the ligation, the so-called D3 surgery. Here we can see two examples of Japanese specimens, are much shorter in length, but with similarly nice intact mesenteries and high vascular ligations. And this concept of central ligation was initially described many years ago now, over 100 years ago in 1909 by a surgeon and anatomist in Leeds, of all places, who described the lymphatic drainage of colon cancer and highlighted that to adequately clear those lymph nodes you need to undertake a high ligation. And we now see lots of examples of high-tie surgery from around the world. So we devised a tissue morphometry system of measuring the amount of tissue resected, and to do this we needed a fresh specimen picture with a metric scale so that we could calibrate and undertake measurements, looking at the length of colon resected, the distance between the tumour and the hyati, the nearest bowel wall and the hyati, and the overall area of mesentery. And we first used this technique in a comparison of Erlangen and Leeds surgery, published back in 2010 now, I think it was. And we split this down into right-sided and left-sided tumours, and when we looked at the Erlangen specimens, we can see around an extra 5 centimetres of tissue removed on average between the tumour and the high vascular tie when compared to Leeds. A little bit of extra length of colon, so 8 centimetres of extra colon. If you take out more length of colon and a bigger distance between the tumour and the hyati, clearly you take out more mesentery, leading to a higher lymph node yield. And you can see when we compare the mesocolic plane resection rate that there was a significant difference there, 87% versus 50%. Similar when we look at the left-sided resections, again an extra 5 centimetres of tissue between the tumour and the high vascular tie, an extra 13 centimetres of colon, more mesentery, more lymph nodes, and a higher mesocolic resection rate. So we feel these are good quality measures of colon cancer surgery, and by undertaking these morphometrical measurements we can compare different series. So on the back of this we went on to undertake a number of studies, first comparing the European CME versus the Japanese D3 approach, and we can see again some small differences with the Japanese D3 on the right side having around just under 2 centimetres of less tissue between the tumour and the hyati compared to the Erlangen specimens. 9 centimetres less length of colon, but a similar mesocolic plane rate and a few less lymph nodes because of that 10 centimetre rule. But when we move to the left side, we can see no difference between the tumour and the high vascular tie, but a big difference in the length of colon. So 26.5 centimetres of additional colon removed in Erlangen compared to Japan. No significant difference in mesocolic plane resections, but we do still pick up a difference in the number of lymph nodes because of that additional length of mesentery resected. We were also able to use these techniques to compare open and laparoscopic surgery, This was initially done in a comparison of CME undertaken by Robin Kennedy and Ian Jenkins at St Mark's versus Erlangen again, and we can see for both right and left-sided specimens that the distances between the tumour and the high tie were very similar, and the length of bowel resected was quite similar as well, meaning the overall area of mesentery was very similar. Mesocolic plane resection rates were very similar. The only difference here was the St Mark's pathologists were finding slightly fewer lymph nodes. And we've also got the similar data from here in Greece, showing for both right and left-sided specimens using the same morphometrical measures that there is no significant difference in the open and laparoscopic approach for CME. Finally, we were able to use the same measurements to look at the impact of surgical training in Denmark. The initial paper we published back in 2010 compared a single hospital, Hillerød Hospital in the Copenhagen region, to the other 5 hospitals. Hillerød had taken themselves to Erlangen and decided to implement CME as standard before a regional education program in the Copenhagen region. So we were able to compare what this one hospital who had previously undertaken training did compared to the other hospitals, and we can see they removed more tissue between the tumour and the high tie, much more mesentery, a better mesocolic plane resection rate, and more lymph nodes. So all of these oncological variables were better in the Hillerød group for both right-sided and left-sided surgery. Following the regional education program, we were able then to look at the other 5 hospitals and see whether they had improved a few years later. And we can see that there is still significant differences between the tumour and the high tie, but the mesocolic plane resection rates have increased significantly. And actually, when you look at the left-sided resections, the mesocolic plane resection rate is now higher in the other 5 hospitals compared to that one hospital where we initially saw improvement. And when you look at the whole region, we've been able to improve through training the mesocolic plane resection rate from 58% to now nearly 80%. So a significant improvement in mesocolic plane resection rates, but when you look at the distances between the tumour and the high tie, we seem to have failed to have convinced the surgeons that undertaking a central ligation is a valuable thing to do. And we know from that region, from the Hillerød Hospital undertaking CME, with their longer term outcomes now translating into around a 10% improvement in outcomes following the introduction of CME. So going back to the variables, for the mesocolic plane, we know from 2 independent studies, that's the initial lead series and the classic trial, that there is an impact in survival with around a 15% difference between the mesocolic plane and the muscularis propria plane for overall survival. And also from the classic trial, local recurrence. So around a 3- to 4-fold increase in local recurrence with muscularis propria plane surgery. I think the evidence for central ligation and how much of an impact that has in terms of overall outcomes is still very debatable. Certainly when we look at the outcomes from Erlangen and Tokyo, they are some of the best in the literature to date. But there is some confounding here that these 2 series have a very high rate of mesocolic plane surgery as well. And how much of that improvement in survival comes from keeping the mesocolic plane intact compared to that high ligation remains to be definitively answered, but I think we feel that the majority of the benefit is coming from the mesocolic plane, and the high ligation probably gives some additional benefit, but the amount of benefit and who exactly benefits from a high ligation still remains to be answered. And then the difference in the length of colon, well, we know from comparing Erlangen and Japan, there's very little in the way of difference in terms of longer term outcomes, but there is a significant difference in operative approach, and we would hypothesize that this probably has the least effect on the overall survival. So some ongoing trials that may bring us some further evidence. We've got the NCRI Foxtrot trial in the UK, which was a trial looking at the impact of neoadjuvant chemotherapy in colon cancer, but built into this trial we have a prospective assessment of mesocolic grades by the pathologists, and when we have over 90 centres, over 80 from the UK and 10 from Scandinavia, so we'll be able to look at the prospective impact of surgical grading by pathologists around those centres. We've got the T-REX study that's already been mentioned, comparing the European CME and the Japanese D3 approach, although this is a non-randomized study. And then there's the question around whether or not we should be stratifying who gets a high ligation. We've done a couple of trials in Leeds. This is the second one, EMI 137, looking at the use of fluorescent agents interoperatively to try and identify metastatic nodes by switching to blue light mode during laparoscopic surgery. And the concept is, if you do have evidence of metastatic disease in the lymph nodes, you might do a high ligation, whereas if it looks like it's earlier stage disease, then there may be some benefit in doing a slightly lower level ligation. So to summarize, I've shown there's variation in colon cancer surgery and outcomes. There's evidence of importance of the plane of surgery in 2 independent series. The benefit of the high ligation, there's evidence of further benefit from both Erlangen and Japan. We've shown in Denmark that multidisciplinary education makes a difference, and in terms of the short-term outcomes, in terms of the oncological quality of the specimen, and now in also the longer-term outcomes with what's looking like a 10% improvement in survival. We know from a number of studies now that laparoscopic CME appears to be as good as open CME, at least in expert centres. And finally, underpinning all of this, pathological quality control is essential to drive improvement. And as pathologists, we need to be taking photographs of specimens, we need to be showing them at the multidisciplinary team meetings, and we need to be feeding back to the surgeons about the planes of surgery, the height between the tumour and the height, length of colon, etc. I'd just like to thank everybody locally in Leeds and our national and international collaborators who contributed to the data, and also Yorkshire Cancer Research who fund the work we do in Leeds.
Thank you very much for the excellent presentation. And
there are just a comment. There are questions from the floor for you over there.
Behind you.
You have to answer, and then from the floor.
Okay. So, first question, any efforts in connecting tissue morphometry metrics with body surface area or BMI? So we've done this in a couple of studies, and there is a clear connection between the distance from the tumour to the height and the overall area of mesentery and BMI, or independently BMI and height. And we've shown that in at least 2 independent studies now. And I think that's why it's very difficult as pathologists to say whether or not this is definitely a D3 or a D2 resection. We can only measure the length on the artery. We can't say what's been left behind. And I think this is where potentially using the post-operative CT scans or photographs of the surgical bed to prove what's been left behind needs to be drawn together with the pathology to reach a conclusion. So we can certainly make a measurement, but because of these differences based on BMI, we can't say definitively whether or not this is a D2 or a D3 operation. Do you have any more?
Don't you think that in order to overcome, the second one is not for you, the question, it's for the previous speaker. In order to overcome the problem, don't you think that we should add to the photo documentation of the specimen the on-table picture? This is the only way to be sure that we have achieved the central dilation rather than measuring the extent. Because I mean, the extent of the mesentery of mine is not the same as of an old lady 1.5 meters tall.
Yeah, I agree. I think if you can clearly photo document what's been left behind, that's
easy.
fine.
It should be added into the whole curriculum of morpholometric measurements of the specimen.
Yeah, I mean, what we've learned, we certainly can't rely on the surgical notes, the operation notes, where we had in Denmark the claim of a high ligation. Some of the cases had 5 or 6 centimeters of vessel left behind, so we do need some kind of documentation. And the CT scan seems to be possible to do this.
Much more expensive, though.
Well, but we've gone on to do a second study looking at the value of the 1-year post-op CT scan, so you can use that rather than do an additional CT scan.
I have a small comment on that and 2 questions. We haven't published that yet, but we had shown that in about 80% of all the cases, we could measure the residual length of the artery at 1 year, and there was hardly any difference to the length that we measured just post-operatively. So in this way, we have a simple way of looking into quality using the CT scan that we're taking anyway after 1 year and stuff. I have a few questions for you, and I'm sorry. The Danish study from the Copenhagen area, do you have enough numbers? Because in some way that's very interesting, because you know that in the beginning the pathology was terrible, apart from Hillerød. You also know that the outcome was much better in Hillerød. Now you have a group of patients where you have shown that, you know, the mesocolic plane surgery was about the same in Hillerød and the other side, but they were doing much more probably central ties. Are you going to look into survival comparison? Because if it disappears, then it's more, as you suggest, it's the plane of surgery more than the level of tie.
Yeah, I guess it depends how far we want to drill into the individual hospitals, because
Yeah, but you can.
when you break down by the site of the tumour and then the individual hospitals, the numbers get small.
Okay, so you don't think there's enough numbers. The other thing, the Japanese for the transverse colon, are they doing similar to what Werner is suggesting or indicating we should do, taking the gastrocolic ligament in all cases?
I don't think so. I don't think, certainly they're still applying the 10 centimetre rule for the transverse colon. So we're still seeing fairly small wedge excisions, but with a high ligation. But on the specimens we've seen, we've not seen any gastrocolic ligaments.
Have you looked into how their outcomes are for the transverse colons flexion? Why not?
We'll have to go back to Professor Sugihara and
Okay, you have to go back. Thank you.
We have time for one question more.
I would like to take the side of Prof. Sinus in terms of doing a picture inside the theater on the table, because doing a CT scan a year after doesn't make any difference to the oncologist who have to decide in a stage 3 or stage 2 cancer if you will give him chemotherapy or not. We have to decide just after theater what we will do with the patient.
I guess it depends on what we're using that information for. Are we using it for an individual patient to influence their outcome, or are we using it to get an impression of the quality of surgery across a group of patients? It's similar for the mesocolic grading. I've shown that it's subjective, and there is intra-observer variation. So on an individual patient basis, it maybe has less use, but across a series of cases where the same pathologists have applied the same principles, then it has value in comparing before and after, if there's been a difference in approach, or comparing different surgeons. So it depends on what you use the information for.
Okay, thank you very much again.